Hello, my name is Arya Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to today's webinar, Virtual Nursing Innovations to Mitigate a Healthcare Workforce Crisis. Today's webinar is hosted by the South Central Telehealth Resource Center, and these sessions are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just a little bit of background on the consortium. Located throughout the country, there are 12 regional TRCs and 2 national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started today. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat feature for communicating issues with technology or communication access issues. Please refrain using the chat feature to ask questions or make comments. Please also note that closed captioning is available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to Joe Schaffner, Assistant Director of Outreach at the South Central Telehealth Resource Center.
Hello, everyone. Thank you for joining us today. Thank you, Aria, for the introduction. And I am going to pull up a slide. There we go. Okay. So I'm with the South Central Telehealth Resource Center, and similar to Aria's map, we are located in red on the map. Our region covers Arkansas, Tennessee, and Mississippi. However, we work frequently with TRCs from, other regions, other states, as well as other professionals. So if you're from the region, if you're not from the region, feel free to reach out and we can chat about telehealth. Want to point you towards our website. Has a robust library of previous recorded webinars, upcoming webinars you can sign up for, upcoming events, podcasts, newsletters. Check it out for any resources. And there's our contact info if you want to chat. All right, so introducing our special guests and panelists for today. Our moderator is Dr. Tearsanee Davis, Director of Clinical Programs and Strategy at the UMMC Center for Telehealth. And our panelists from the Medical University of South Carolina Center for Telehealth are Kayla Dillon, Telehealth Outreach Coordinator, Eric Quinlivan, Clinical Outreach Coordinator, Shay McLeod, Nurse Manager of Acute Services, and our panelists from the University of Mississippi Medical Center, Center of Telehealth are Dr. Saurabh Chandra, Chief Telehealth Officer and Assistant Professor of Medicine, Greg Hall, Director of Information Technology, and Brianna Petty, Director of Nursing Adult Services and Nursing Administration. So, Tearsanee, I'll turn it over to you.
All right, good afternoon, everyone. We are excited to share our thoughts on virtual nursing from the respective organizations. I will not introduce the speakers, panelists. I'll let them tell you a little bit more about themselves. We've heard names and titles and organization affiliation, but I think it will be helpful when you do describe your program to tell a little bit about your connection to the virtual nursing program at your respective site. So I guess we'll start. Again, like I said, this is just for you to give a little bit about yourself, your connection to the virtual nursing program, and give a little bit of context that includes the type of facility, and then also the target population for your virtual nursing program. And we can start with Shay.
Hey, good morning or good afternoon, everyone. My name's Shay McLeod, and I am the Acute Services Nurse Manager for telehealth at MUSC in Charleston, South Carolina. So I am a nurse by background, and I've worked in telehealth in the manager role for about 4 years in operation. And a little bit about sort of how I help to support virtual nursing is really from kind of start to finish. So starting in the development of the program, working to implementation, and then maintenance phases. So that's just a little bit about how I help to support VRN.
Thank you. Dr. Chandra?
Thank you, Tearsanee. Saurabh Chandra, Chief Telehealth Officer here at the Center for Telehealth at UMMC. I'm a critical care physician by background. And prior to moving to Mississippi, I was a medical director for Tele-ICU at Northwell Health in New York. And that is where in 2014, I started the Tele-ICU program. And most Tele-ICU programs in the country are hub-based programs where nurses, nurse practitioners, physician assistants, and physicians all work together. So my experience with virtual nursing started as my role evolved as the medical director of Tele-ICU. And when I moved here at UMMC, always wanted to implement a program, especially during COVID and after COVID, when we were seeing higher turnover rate for nursing staff and nursing shortages here in Mississippi and throughout the country. And then, worked collaboratively with our colleague, Brianna Petty and others to implement the virtual nursing program here at UMMC that we would love to talk more about today. Thank you.
Thank you. Kayla?
Hi, everybody. So happy to be here today to talk to you guys about this. My name is Kayla Dillon. I'm a clinical outreach coordinator with Medical University of South Carolina. I'm a nurse by background as well, and I am on Shay's team working closely with other outreach coordinators. And I've been in the Center for Telehealth for about 3 years now, and I work closely with the VRN service that we have as a clinical outreach coordinator because we are outward facing towards the MUSC partner sites and also within the Charleston network, which is the main hub for MUSC. And so we have a very close relationship with the unit managers. And so we're really kind of the liaison between Virtual Ally, which is our vendor company, and then MUSC leadership team. And so we kind of help the transition. And as Shay said, we're very much heavily involved in the development process. We talk about workflows, we develop all of those things, and then we transition into the training piece. So we go on site, we do a mix of virtual and on-site training with the nurses to get them comfortable with the platform, the technology, just reinforcing education, doing talking points about the service, when to contact, what to contact for, how the workflow goes, and then also into the maintenance phase. So we bridge any gaps between Virtual Ally and MUSC leaders. We also work on QI projects, any kind of initiatives that the units are doing. We support those and kind of bridge that gap and just bring everyone to the table to talk about how to best improve the service.
Thank you. Brianna?
Hey, good afternoon. I'm Brianna Petty. I'm the Director of Adult Nursing Services at the University of Mississippi Medical Center. And so I am the director over our current units that have the virtual nursing program. And as Dr. Chandra said, I was first introduced to virtual nursing shortly after COVID started, and we saw a lot of our nurses exiting the bedside. Our vacancy rate went up, and we were trying to get creative on what we could do to help keep nurses and help support them. And Dr. Chandra and his team with telehealth stepped in, and that's kind of where our vision of virtual nursing was born. And so I have had the pleasure of getting to know the telehealth team. That is not traditionally my world. I am in the hospital in the inpatient setting, but it has been a great collaborative relationship, and we're really excited about where we're going.
Thank you, Brianna. Eric?
Good afternoon, everyone, or good morning, depending on where you are. My name is Eric Quinlivan. I'm also one of the clinical outreach coordinators for the Medical University of South Carolina's Center for Telehealth. I work alongside Kayla and Shay, our boss, to help support our partner sites in all telehealth endeavors. We all work together to cover our South Carolina partner sites with telehealth services, including VRN.
Thank you. And
I'm Greg Hall. I'm the Director of IT for the Center for Telehealth at University of Mississippi Medical Center and the only non-clinical person here, right? So I've been with the university for 25 years, been with our telehealth program since we started it. Started the center back in 2011 and actually started our first telehealth program in 2003. As my title would suggest, I help guide any of our telehealth initiatives on the technology that's being used, and then the implementation phase, actually implementing the product, and then ultimately going into the maintenance phase to be able to maintain the program. So when Brianna and her team have run into issues, is my team that they call to resolve those technical issues.
Thank you. So now we know who everyone is, and we'll move right into our discussion today. So there's some conflicting thoughts on virtual nursing, like what that actually means. And so I know there are lots of statements. I've seen things written that say that it helps with the nursing shortage, and I've seen things written that says that it doesn't help with the nursing shortage. So I'd like to hear from Brianna or Dr. Chandra, whichever one. What is your take on UMC's virtual nursing program and the impact on the nursing shortage? I know Brianna mentioned a little bit about concerns about nurse staffing after COVID or during the COVID pandemic. So Brianna, I'd like to start that off, and if Dr. Chandra has anything to add, you may do so.
Okay, yes, thank you. So I will say, when we started our virtual nursing program, we had a few goals in mind. And the first thing that I think is on our frontline staff's mind is, are you trying to get rid of nurses at the bedside? Is virtual nursing coming in to replace us? And I will say, from a UMC standpoint, that was not our goal. Our goals were to reduce that nursing workload, enhance patient-centered care, and improve staff satisfaction and retention. So that is how we entered the program, with those goals. And so our workflows were set up initially to focus on discharges, admissions, and then some rounding. So really to do everything that we could to support our frontline staff virtually. And we were able to do that. In the first year alone, we started our phase one. Let me start over. We started our phase one on a 14-bed med-surg unit. So it was a very small unit. And we did this because we wanted to make sure all our technology worked and we had the right workflows in place, and that this was going to be successful. So on that small unit of only 14 beds, in the first year alone, we saved the frontline nurses 550 hours of care at the bedside. So that was only through admissions and discharges. And so that was a significant lift for them. We did some surveys pre-implementation and post-implementation, and what we found with their satisfaction scores, with how satisfied they were with the admission process, that improved from 54% pre-implementation to 93% post-implementation. The discharge process went from 38% to 78% satisfaction. And then most importantly, the overall workload, pre-implementation, it was 54% satisfaction, and after implementation, or a year after, it was at 79%. So we certainly saw satisfaction from our surveys and hearing from our staff. But how did it truly impact UMC? We had 0% RN turnover for the first 18 months that we had this program in place. And that was huge, because we were coming off of COVID 2 years in. All of my areas, I have about 300 patient beds that lie under me, and we had a 65% RN vacancy rate. And so it was huge to not lose a nurse from that unit for the first 18 months. We just got done taking Press Ganey employee engagement survey. We did that here in February. And so this unit now has had virtual nursing for 2 years, and they are the highest unit in our entire adult hospital, so the highest inpatient unit for employee satisfaction. And I think that just speaks volumes to what we've done, what virtual nursing has done, and how much that has impacted them at the front line. And so we've seen a lot of other successful things, and I know we'll get into this more as the webinar goes on, but we have added another component. We switched vendors in February. So we switched vendors and now we have an AI component, and we have added virtual observation. So we're now focusing on our high fall risk patient using that AI technology. And so we're excited to see how that just continues to engage our nursing staff and help keep our patients safe. But we certainly have seen big wins around nurse retention.
Thank you so much for that. Dr. Chandra, do you have anything to add at this point?
So the only thing that I can say, Tearsanee, is that when you talk about workforce shortage and whether a virtual nursing program can mitigate, workforce shortage, in traditional way, what you are trying to, refer is that can it actually replace the bed shortage of nurses at bedside? And we all know that there is a huge shortage of nurses. In 2026, it's projected that 10% shortage in RN workforce, totaling to about more than 300,000 RNs, positions being unfilled. So the question is, it depends upon what is your intent behind the program. Our intent here at UMMC was not to replace the bedside nurses. Our intent, as Brianna said, is to provide support, actually reduce, burnout, increase their, work-life balance, and thereby, able to retain the nurses that we have. And I think, as Brianna mentioned, that has been very successful. But in other ways, if you can use it, and we are trying to implement that. There's a small rural hospital in Mississippi where we are trying to set up a small ICU. We just met them last week, and they said we do not have trained critical care nurses. And we suggested whether we can bring in critical care nurses who can provide support, guidance, and recommendations using our telehealth platform. Can the bedside nurses be not critical care trained? And would that paradigm where a non-critical care trained nurse at the bedside can be supported by a critical care nurse with a number of years of experience in ICU setting? And they were very excited. So if you look at that kind of a model, so it depends upon what your intent is, what kind of model, and based on that, in this last model that I talked about, if we are able to set it up, we will definitely be able to kind of mitigate shortage of critical care nurses at the bedside in smaller hospitals.
Thank you both. So Kayla and Eric. So, as with any new approach to healthcare, we must have a why. And this why can help us gain support for our programs. So, and it does also help keep us focused, because we can start something and kind of get drawn off to the side and forget the reason why we did this. So I know that you all are looking at the data. Can you share some of the important metrics that you all are tracking and tie that to a value proposition? Like, how would you use these metrics to sell the program?
Yeah, so I can start by just giving a little bit of background as to the original why that we had for our VRN program. I was fortunate enough to start what we call the VRN 1.0. I was one of the nurses that started that program, and the vision was really a mentorship program for bedside nurses, just a safe space for them to ask questions or to talk about their patients, especially those higher acuity patients on the med-surg floor that you don't always feel comfortable asking a preceptor because you're the new grad on the floor, and it was specifically targeting new grad nurses. And so we did this for several months, and then we shifted because we realized that the demands and the needs were evolving as well. And so there was really a demand and a need to support throughput through the hospitals. And we share the sentiments from the other hospital on the call that we didn't want to replace the bedside nurses. We didn't want them to feel like someone was coming in in and trying to take over their job. We really wanted to alleviate the administrative burden by doing those heavy lift, admission questions and discharge teaching, the stuff that's not necessarily hands-on, that can be not supplemented by by a virtual nurse, done by the bedside nurses. And so we shifted, and we really just kind of tried to hone in on the best way to do admissions and discharges efficiently. And we really worked hard on developing this workflow that would support the bedside nurses and having that closed loop communication. So we have very thorough documentation, a very open line of communication through Epic Secure Chat between the VRN team and the virtual ally team. And the data has just supported how great the service has really taken off. And it's not just MUSC Charleston, it's through the whole MUSC enterprise. I would be remiss to say if there wasn't some pushback originally from the bedside nurses. They're like, well, nobody can do discharge teaching better than I can, and no one knows the unit like I do for admissions. But they've adopted well. I think once they realize that we're really there to support them and not add any work, we're here to take the work off of them, it has grown leaps and bounds. And there's another slide right after this one that kind of supports some of the data that we're tracking. Just a testament, 500 days. When I saw that, I was kind of shocked myself. 500 days given back to the bedside nurses. And our program, I think the first unit went live in October of 23. So we've been live, a year and a half, but just 500 24-hour days given back to the bedside nurses is just such a huge impact. And I can let Eric kind of speak to more of the data, but yeah, this slide shows a lot of what we're covering.
Yes, I'm sorry for that. So just to kind of expand on what Kayla had said, we like to take a look at really everything. And I'm sorry, I'm having some technical difficulties. Okay, there it is. For some reason, I don't have the right view. I apologize, folks.
Eric, if you want me to hop in,
No, I'm sorry, I got it. So just kind of backtrack a little bit. When we initiated the program in current state, we went to try and go to somewhere between 20 to 40 monitored beds per VRN nurse. As Kayla has expressed, really concentrating initially on admissions and discharges and providing some education. They do some lab review and rapid response escalation. If there's patient issues during consult, we make sure to get that information to the floor staff immediately so that they can get the acute care that they need. Making sure that all the documentation as far as quality review and support is completed, and then working our standard workflow, based on as patients are requested for assistance by the units, that would be the order that the patients are cared for. So first come, first serve as they work that queue. What we found was that the best way to kind of speak to each other was through a secure chat in Epic. So direct nurse-to-nurse care in the moment. 31% of those service units that we have supported did require videos. So those would be active education plans, intakes for admissions and such. Over 600 covered beds in virtual nursing. So our total bed count at this point is about 600. That is over, I would say, about 7 of our acute care hospitals. At this point, we are trying to bring all med-surg and some specialty units up with some form of virtual nursing to assist in these tasks. To date, we've got almost a little over 16,000 patients that have been served, with over 26,000 service units completed. These service units are initiated by the bedside staff 70% of the time. So the bedside staff would be reaching out to us for assistance in these tasks. And that's, at the request of the bedside nurse. And as Kayla had mentioned, almost 500 days, so full 24-hour shifts given back to bedside nursing since the first units went live back in October of 23. So just a huge expansion from our initial thought. And, I think even before VRN as a formal product went out, I started with the organization in January of 2020 in telehealth specifically. And within 2 months, the world changed. COVID hit, and we quickly were changed from inpatient support to outpatient ambulatory support, and to try and keep patients out of our EDs if they had stable, symptoms with COVID, and monitor them at home. So it's really come a long way The focus of this program is specifically to assist the nurses at the bedside and try and give them back some of their day to try and compensate for some of the nursing shortages that we experience.
And I wanted to add here too, some of the data that wasn't shared. We didn't see quite the same outcome as no turnover, which congratulations to you guys. That's a big win. But we did see a drastic decrease in the turnover. One of my sites specifically saw a 50% decrease in just the last 6 months in their unit turnover, which was a great win for them because it seemed to be happening quite frequently. And also, we have seen a lot of success with the Press Ganey scores that came out with nurse satisfaction. So that was also a great win. And also, we've tried to align the VRNs whenever they're doing discharge educations to hit the highlight kind of lingo that you see in the HCAP scores that are sent out to patients after they discharge to kind of ring a bell so that there's a more positive response from the patients. And we have seen some better compliance with people doing those HCAP surveys, and then also just better results after the VRNs kind of touch that patient. So great success with that too.
Thank you both. I'm going to switch gears just a little bit here and talk about the technology. So we've been talking about, the program itself and the outcomes as far as the nurses are concerned and how many people we've been able to help with it. But I want to go back just a little bit and talk a little bit about the technology. So I'll start with Greg, asking, can you give us a description of the type of technology that we started with the VRN program, and then kind of give us an overview of where we are today as far as what we're adding now, particularly AI, because I know people are very interested in how AI can help us in this space.
Sure, thanks, Tearsanee. So our initial platform at UMMC was actually just a camera and a microphone in a room, and nothing more complicated than that. It was a Pentel Zoom camera, so the virtual nurse did have the ability to zoom across the room and be able to zoom in on the patient. The other thing it did enable was a little bit of privacy for the patient, so you could point the camera completely up, so the patient wasn't worried about them being spied on 24 hours a day. So those initial technologies enabled the virtual nurse to have that interaction with the patient very fluid, just like they would if they were in the room. Switch over to the gears of why we chose to choose change technology in the middle of the program after only having that in a year. It had absolutely nothing to do with virtual nursing, ironically enough. It had to do more along the lines of additional services that could be offered through the technology. So we did switch gears to an AI-enabled technology that allowed additional components such as fall risk prevention, and Brianna kind of touched on that during her presentation at the beginning. The AI is actually keeping track of the patient in the room and notifies not only the virtual nurse, but we also have an observer as well, that their core responsibility is to make sure that if somebody is showing signs of getting out of the bed, that observer is the one that is responsible for actually trying to change the course of the patient, trying to get them to stay in bed until a nurse can come in and help. And that AI component really enables those observers to not have to sit there and closely monitor every one of the little, Brady Bunch boxes, but they actually get notified, hey, somebody's about to get out of bed, or no, somebody is getting out of the bed, you need to act now. So it does give those alerts in addition to just the visual cue on the screen. The other things that we are working towards that the AI assistant is going to be able to enable is additional workflows for our nurses in the room. So we're not there yet. So I'm talking about a little bit of future state, not future state years to coming, but in months to coming for our nursing team. So things like being able to walk into a room, state that you are a nurse, and be able to document oral care is a perfect example. So you could just walk in and say, hey, I'm performing oral care on the patient in 323. It'll open up the Epic chart and indicate that on the Epic chart. The next time the nurse has their rover, it's just a little check saying, yes, I actually did do oral care. So instead of having all those extra steps of having to log into Epic, we know how long that takes when you're not in a session. It's going to save the nurses a lot of time to be able to cut steps out of having to do that awful thing of typing in a password. Yes, even technologists hate passwords. It's not just the clinical team. So then AI is really enabling us to change workflows and better enable the nurses to do what they're supposed to do, which is actually taking care of patients and not always sitting there on the chart and having to document what they're doing in the chart.
That's great. Thank you. So Brianna, I'm going to go back to the nurses, and Brianna, you can answer this, and Kayla talked about this a little bit. I'm not sure if Shay has anything to add about this, but going back to the nurses, I know, Brianna, you shared with us the nurse satisfaction outcomes here lately with the Press Ganey and all of that. But how did they feel about it in the beginning? And what did you have to do to get them to buy into it?
Well, I will say at the beginning, I think everybody was excited, a little hesitant because this is new to the nursing world. And so what does this look like? How is this going to work? And so right out the gate, we did notice that, they were excited. So we did a survey at the beginning, which I shared some of those results with you, but we also did it 6 months in. And what we found 6 months in is that our staff went polar opposite. Some of them loved it. Some of them did not. We saw really low scores. And so we had to go and talk with them and ask what's going on. And so what we heard from them, because it was a smaller unit, is they didn't understand why they couldn't just have that nurse at the bedside. We just want the nurse to be here with us at the bedside, not virtually. And so we had to explain our bigger vision. And I think part of that was they just didn't understand that this was phase one and how this is growing and how it's expanding. And like Greg said, all of the things that will be coming in the future. And so once they understood that and really saw the full vision, then we saw after the year mark, certainly their satisfaction went way up and they understood. But a lot went into getting their buy-in in the beginning. We hired 2 virtual nurses to begin with, and one came internally, one came externally. They both have done a great job. We really did not see a big difference on the one that was internal versus external, because what we did at the very beginning was we took them physically to the unit that they were going to be doing the virtual nursing on, and we built those relationships face to face. So we had them work with the nurses, orient to admission and discharge process, especially the external one. Let those frontline staff really get to know the virtual nurse and who is behind the screen. And we got that tip from another organization that we went and visited, and they said that was the key to their success, was really getting those nurses together at the beginning, and forming those relationships and building that trust. Because I think that's where it comes in, is I have to be able to trust, if we're going to co-manage this patient, I need to be able to trust that, you understand the workflows and that we both have, the patients at the center of care. And so that was really important, was to do that. We also have our virtual nurses on campus. So they are not off-site. They are on campus. They do attend unit meetings. Now, as we continue to expand, that may not be possible, but our frontline staff still get to see them face to face every now and then. And I think that has truly helped get the buy-in and engagement from these first couple of units that we've started doing, because they have those personal connections and relationships with our virtual nurses.
Thank you, Brianna. Does MUSC have anything to add about the nurse buy-in?
Hey, I really echo a lot of what was just said. I think those are sort of some of the big challenges, the trust, sort of the unknowing of what the service quality will be, I think were barriers for us as well. And one other sort of piece to add, I think, would be the discomfort with the technology as we first started, and nurses sort of having to learn another new piece of equipment and kind of be in charge of that, I think was something to work on for us as we started to roll out. But just sort of anecdotally, we did just do an interview with our director of nursing at MUSC Lancaster, which was our first partner site that we started the service with. And she had a great comment that her unit went from hesitancy to success, and really just described some of the same things we were just talking about by really involving the virtual nurse team with the clinical team. So whether that be on-site training, continued education as needed, just knowing that they have support, not just in the beginning when we start services, but as we continue in the maintenance phase. So part of that is including the clinical team in quarterly quality meetings where they feel like they can continue to voice concerns. I feel like has really helped with the success and sort of trickled down to the bedside team.
Thank you. So Dr. Chandra, you're not off the hook. I know that you are a researcher at heart, and we're talking about metrics a little bit here in this session. Specifically, you as a chief telehealth officer, chair of a department, having to speak often with senior leadership at the organization. What metrics do you think that they are interested in as it relates to virtual nursing? I know we started our program, on a grant, but grants don't last forever. So what do you think are the metrics that will be important for anyone working in virtual nursing to be sure to track, and how do they translate that, into the language that the senior leadership would take interest?
So thank you, Tearsanee. So there are, as you know, there are a lot of stakeholders. There are clinical leadership, nursing leadership, operational and financial leadership, all looking at the program with a different lens. And our job is to cater to everybody's, point of view and what they are wanting out of the program. And of course, as Brianna would agree, the nursing leadership, when we started with implementing the program, the whole idea was that how this can improve the work-life balance, the retention, reduce the burnout of the nurses. So that was our main focus, on improving the quality of life for the bedside nurses. So keeping that in focus, we captured data on how many hours the virtual nurse can take off and reduce the administrative tasks from the bedside staff. She has great data that, when the virtual nurse is, doing the admissions, discharges, or rounding, it takes away, time that you can give back, actually, time to the bedside nurse to take care of themselves or do more clinical work. So that was our intent. And I think other metrics that we have collected and Brianna shared was satisfaction from the bedside nurse on these processes, with the discharge process, with the admission process, with the rounding. And we have gradually seen, as she mentioned, that there were initially some reservations, but with time we have seen great data on the satisfaction from the bedside team for this program. So that was where our initial focus was. But together with that, I think we are looking at the financial cost, because a big question that everybody wants to know in the leadership is, how can we expand, scale the program? Can it stand on its own leg? Can it be sustained? And we are looking, especially when you are, implementing technology like AI. Technology is expensive, licenses and everything you have to take into account. Also, you have to take into account staffing costs. So one of the our now secondary focus is to be able to scale and sustain the program. So we are looking at metrics like, as Greg mentioned, with the AI, we are trying to prevent falls, and we are looking at pre and post implementation data on falls, which may be falls with harm, falls without harm. And as we all know, whenever falls occurs on the floor, and then we have to report that, and it is not only reported internally, but also reported to CMS. There can be penalties that can come along with that, and that can also lead to sometimes having lawsuits whenever falls. So fall is a costly for just in terms of dollar amount. It is something, and of course, harm to the patient. It is something that leads to significant costs. So we are looking at our historic data and then looking at the data on how many falls are being prevented and looking at reduction in costs that comes along with that. And I'll have Brianna, talk a little bit about the number of falls that she has seen in the 2 units that we just implemented the AI. But before I hand it over to her, so we are looking. They're very interested in the impact on our nurses, but also looking at operational costs because the question is, how can we scale it up? And so far we have seen good data. But in addition, when you're talking about operational costs, you're looking at nursing turnover costs. You are looking at burnout index. You are looking at overtime costs. So there are good variables that everyone can collect, and we are in the process of collecting to make a strong case, because the leadership is looking for different variables, like, hey, the quality of improvement of bedside nurses, and what is the prevention of falls, costs associated with it, and the whole point is, can we scale it up? So I'll hand it over to Brianna to talk a little bit about the number of reduction in the falls that she's seeing.
Yes, Brianna, just before you answer, and you can answer, I wanted to go ahead and give the rest of the panelists an idea about what the next question is going to be, so you're thinking about that, and then also to encourage the attendees to use the Q&A box and go ahead and begin to put your questions in that box so we can have time for questions. So we'll start with Brianna, but for the rest of you, if there is something pressing, a lesson learned, something that you have now learned your lesson about, that you could pass on and prevent someone else from having to go through that same heartache, you can share that after Brianna finishes up this question. And then we'll move to the Q&A box if we have any questions.
Thank you. And yes, just to echo what Dr. Chandra said, we are looking at a lot of different KPIs, really trying to build a case to expand this and really show what it has done for us. The virtual observation piece and the AI technology is definitely going to be big for us. We're focusing on fall prevention. We started our virtual observation with the AI the beginning of February. And so I have February's fall data and I have March's fall data. And so what we've seen for North, which is our new unit, it's a 32-bed unit, and our goal for the organization and for this unit is 3.5 falls per 1,000 patient days. This unit for North had hit that target maybe twice in the past year. And so both February and March, they had been well under that goal. February, they were at 2.35 falls per 1,000 patient days. And I don't have the exact one for March yet because we're still collecting our patient days, but it will fall under that as well. It will fall well under 3.5. And so we're seeing that trend down. 6 West also has stayed under target, but I will say they have been doing well with falls even before this implementation, but they are still staying well below our target. So we will consider that a success. One thing that I do want to share, though, is since we started this the beginning of February, we are monitoring all of our high fall risk patients. So we're monitoring the patients that we suspect will have a fall. we have only had one patient fall this entire time. And unfortunately, that patient was non-compliant and did not want to listen even to our observer. And so that is unfortunate that that patient did fall. It was with no injury, but we have only had one fall out of 46 beds monitoring all of our high fall risk patients. And I believe on my slide earlier, our virtual observers, we have tracked that they have intervened, meaning they have reached out, spoken with the patient, redirected the patient over 950 times since we started. And so that's a huge number. And most of that is keeping our techs and our nurses from having to intervene and go in the room. So it is giving them time back as well. And it's just that real-time interaction. And so I think that as we continue to monitor this data, we'll see even more success. So this definitely, we haven't tied it back to a financial component yet, but we will do that. And that should be pretty significant.
All right. So does anyone have anything, a lesson learned that you want to share with the group? It's okay if you don't. I did hear a few things. I heard a few things as we were going through this. As far as the nurses are concerned, don't leave the nurses out. They need to be involved in the beginning. And I believe MUSC said they have a certain period of time where they go back and revisit what the nurses have to say. I've heard here, make sure you have some metrics that you know up front you would consider to be success. And I mentioned that one in particular because oftentimes we do the work, we know why we're doing it, but if someone were to ask you was it success, we have the anecdotal stories, but we don't really have the numbers to support that story. And also I hear from start somewhere. So when Greg mentioned the technology that we had in the beginning, it was very simple and straightforward. And now we're layering on top of that things that can, improve the efficiency of it even better. So those are the things that I pulled from it that I would say everybody should consider if moving toward a virtual nursing program. So we do have a question. So the question is, what is your governance model? Does VRN fall under IT, nursing, or strategy? So, yeah, go ahead. That's right.
I will speak to it from our standpoint. Right now, our virtual nursing staff, they report up through one of our nurse managers and through myself, but our IT definitely supports us with our equipment and our technology, and the Center for Telehealth is also supporting us through grant funding and other avenues as well. So I think it's definitely a team effort. But in our current state, with ours still being fairly small, it is reporting up through nursing.
At MUSC, is it under nursing as well?
Yeah, I think we're a little bit unique because we partner with a vendor that provides staffing, and so the staffing portion comes through them. But then similarly, the operational support is coming from the Center of Telehealth. So we've got a really close partnership with our vendor.
Okay. All right. So, and we have one more question. How do you deal with the notion of VRNs becoming a burden, bothering the bedside nurses instead of being a support role?
I can kind of speak to this just from my experience. We definitely feel like we get some pushback a little bit from the bedside nurse, especially with technology. It does seem to be a burden. Obviously, we know tech either wants to work or it never wants to work. And we use a cart that has to be physically rolled into the room from the bedside nurses. So there's really a lot of back and forth sometimes. So the best way that we've found to kind of help with that burden is we really have leaned on our telehealth tech support team to give real-time IT support, where that wasn't really available in the beginning. It was just kind of doing education with the sites to make sure the carts were plugged in, rebooted if you're having issues. But now we have a designated virtual ally VRN chat directly with our TTT team, and they're able to just have a direct line of communication with someone. If they're having cart troubles, they're able to jump in and immediately check configurations, call the site, troubleshoot, so that there's minimal going back and forth on the bedside nurse. There's more of someone on the telehealth tech side that's managing the difficulties with the equipment. And we've seen a lot of improvement. There's still obviously hiccups and bumps in the road, but I feel like I'm fielding a lot less complaints because we have that. So.
Thank you. And this is a really good question. Do your virtual nurses contact the providers directly if there's a concerning symptom? And if the virtual nurse is the one who contacts the provider, how is the relationship from your providers to your virtual nurses?
So I will speak to that from our end. Currently, right now, if there's a concerning symptom, they would contact the bedside nurse to contact the provider. Down that workflow, we are looking at some things with the deterioration index and maybe allowing the virtual nurse to contact the provider in the future. But that's not to say they do not contact the providers. There are many times throughout the day that our virtual nurses will reach out about different things. But if it is direct patient care or there's concerns about something physical going on with the patient or a need, they will let the frontline nurse make that phone call.
Yeah, as I was listening and thinking about the question, I was trying to think about in real life, like what would be the difference. And I think when you're calling a provider, you need to be able to do an assessment and answer any questions pretty readily that they might have. So that's where it would make more sense for the bedside nurse to do the calling. But if it's something like an order has expired or something like that, then of course, the virtual nurse should be able to handle that because no assessment would necessarily be involved. So I think that's a good way to think about what they can call for and what they should not call for. That's my little 2 cents. And then the last question is about, can we please get a little more specific examples about the discharge and which use cases? So I think both organizations are using it for discharges. And so they're asking, like, how do you determine what types of discharges? Are they doing all discharges? And then the person asking the question, you can please correct me if I was wrong in my synopsis of your question.
That's a great question. I'll hop in from the MUSC side for discharges. We definitely do all discharges. We've noticed we are rolling out to all med-surg floors within the MUSC enterprise, but there's obviously a lot that are specialty floors. And so what we're doing is we're bringing in the CP&Es, the educators, the big key stakeholders in the education process, and they're doing tailored education for the virtual nurses to make sure that they're hitting all the key highlights, especially like the cardiac patient population, the transplant patient population. We did actually go live on a transplant floor recently, and while there's education that the virtual nurse can do, there's very, very specific education for fresh transplant patients. So they kind of teased out, this is a good example of discharges that the virtual nurses don't handle, is fresh post-op transplant patients when they're discharging. But if they were a recent transplant patient that was readmitted, but they were a little bit further out from the transplant, then they felt like that was appropriate for the virtual nurse to do, just with some tailored education for them. But otherwise, we do handle most discharges with proper education. And we do rely on the bedside nurses to ensure that all of the education is put into the AVS. So our virtual nurses don't bring in anything into the AVS. They rely on the bedside nurses to make sure everything's included, just because they have the bigger picture of the patient and their stay. But they do everything, and they cover whatever's in the AVS by the bedside nurse.
And I will echo and say that our process is very similar. And so there's not much difference. We do make sure that our virtual nurses understand the education, especially for that specific unit or that population. But most of them have worked, on the floors or have that level of experience where they've actually caught some things that haven't been in our AVSs, and they've been able to help get them there. So they definitely have some focused eyes on discharge. They don't have as much going on, and so they're able to focus in a little more. So we've seen a lot of success there.
And thank you all. I think this was a very informative session. Hopefully, we answered any questions that the attendees have at this present time. But I'm going to pass it back over to Hari, Joe, or Aria, and see how they want to give further instructions to everyone. But thank you to all the panelists for taking time out of your day.
Thank you, Tearsanee.
Yes, thank you all so much again. I'm just going to bring up our closing slides here. Just a reminder that our next webinar will be held on Thursday, May 15th, and that will be hosted by the California Telehealth Resource Center. The telehealth topic is to be determined, but the registration information will be posted soon on the consortium events page at telehealthresourcecenter.org. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar, as your feedback is very valuable to us. Thank you again to the South Central Telehealth Resource Center for hosting today's webinar, and to all of our presenters from both UMMC and NUSC for their presentations. Have a great day, everyone.
Thank you.